Hi, my name is Monica Boyer, and I'm a nurse practitioner at Chalk Children's Specialist Division of Metabolic Disorders in Orange County, California. I would like to thank the AGSD for the opportunity to speak today and share our case study of a patient with GSD IX gamma 2. The objective for today's talk includes a brief overview of GSD IX and the various liver subtypes, followed by a case study from our patient population. Glycogen storage disease type 9 is one of the most common forms of GSD, with an estimated incidence of 1 in 100,000 live births. GSD IX is caused by a defect in phosphorylase kinase, which impairs the first enzyme in the glycogenolysis pathway and is triggered in the fasting state. It is responsible for phosphorylating and activating muscle and liver glycogen phosphorylase. The phosphorylase kinase enzyme is a heterotetramer composed of 4 subunits. The alpha and beta subunits are regulatory in nature, and the gamma subunit contains the catalytic site. The delta subunit is represented by calmodulin. Liver PHK deficiency can be divided into 3 subtypes based on the gene in which the pathogenic variant occurs. The alpha subunit is encoded by the PHKA2 gene in the liver. Inheritance is X-linked, and this subtype is the most common of the GSD IX subtypes, encompassing approximately 75% of liver PHK deficiency. The beta subunit is encoded by the PHKB gene. Inheritance is autosomal recessive, and this subtype is less common. The gamma subunit is encoded by the PHKG2 gene. Inheritance is autosomal recessive, and this subtype is the focus of today's talk. The clinical spectrum of GSD IX gamma 2 is usually more severe and includes an increased risk for liver fibrosis and cirrhosis. The naming of the various subtypes can be confusing. The nomenclature listed here all refers to the same disorder. You can name the condition by the genetic defect, PHKG2, or reference the disorder by the Roman numeral assigned to represent the mutation, GSD IXC, or by the Greek letter referring to the mutated subunit, GSD IX gamma 2. All are technically correct. For consistency throughout this talk, I will refer to the disorder as GSD IX gamma 2. Recent published work out of Duke University attempted to characterize the natural history of the various GSD IX liver subtypes and investigate genotype-phenotype correlations. The findings from a total of 30 patients with liver GSD IX gamma 2 were summarized by the authors. They found that the vast majority of patients, 93%, presented with hepatomegaly. Other symptoms that were noted at the time of the initial presentation included hypoglycemia, splenomegaly, seizures, delayed growth, delayed development, cholestasis, and abnormal liver functions. All patients presented clinically with hepatomegaly. Liver functions were available for 22 patients and were all abnormal. Liver biopsy was performed in 24 patients, and 23 out of 24 patients displayed either fibrosis or cirrhosis. The clinical presentation of most patients with GSD IX alpha 2 and beta is milder with age. However, the symptoms of GSD IX gamma 2 patients have been shown to persist with age and potentially progress to cirrhosis, liver failure, hepatocellular carcinoma, and even death. The mystery of the disease disparity between the various GSD IX subtypes is thought to be due to the function of the gene. The gamma subunit houses the catalytic site, and damage to this area, as opposed to the regulatory sites, is theorized to cause greater enzyme impairment and thus more severe disease. Published guidelines exist for the expert management of GSD 6 and 9 and include recommendations for hepatic surveillance due to the high risk for serious liver complications. Regular blood glucose and ketone monitoring due to the risk for symptomatic ketotic hypoglycemia. And nutrition interventions with the goal of preventing primary manifestations, hypoglycemia, ketosis, and hepatomegaly, and secondary complications, short stature, delayed puberty, and cirrhosis by improving metabolic control. Nutrition interventions include a high-protein diet, avoidance of simple sugars, and cornstarch as needed to prevent overnight hypoglycemia. I would like to now share Chalk's experience with a patient with GSD IX gamma 2. Our patient was a male, and he was born and lived in Mexico for the first 8 years of his life. While in Mexico, hepatomegaly and developmental delay were identified, but the details of those medical evaluations are unknown. Other clinical features noted in his early childhood included muscle weakness and gross motor delay, resulting in delayed walking until 20 months of age. He was also noted to have microcephaly and intellectual disability requiring special education schooling. He had a first seizure at 3 years of age and was seizure-free until 11 years of age, and then started on anti-epileptic medication. His family relocated to the United States at 8.5 years of age, and the quest began to try to identify a unifying diagnosis for his constellation of symptoms. Once in the U.S., medical evaluations noted intellectual disability, seizure disorder, short stature, abnormal liver functions, and muscle weakness, but no reports of hypoglycemia. At 12 years of age, the patient underwent an open liver biopsy and muscle biopsy for diagnostic testing. His liver biopsy findings were consistent with cirrhosis and increased glycogen content documented by histology, electron microscopy, as well as biochemical measurement. And at 12.5 years of age, he was referred to Chalk Metabolics for evaluation. Biochemical evaluation was significant for fasting ketosis with beta hydroxybutyrate as high as 18.5 milligrams per deciliter. A GSD was suspected, and tissue samples were sent to Duke University, and GSD types 1 through 6 were systematically evaluated and ruled out. The last GSD subtype to be considered was GSD IX. Phosphorylase kinase activity was evaluated in liver tissue and found to be deficient, and sequencing of the PHKG2 gene identified one missense mutation and a frame shift mutation consistent with GSD IX gamma 2. Once the diagnosis was made, management shifted to prevention of primary manifestations and surveillance for known liver complications associated with GSD IX gamma 2. Nutritionally, the patient was maintained on fasting precautions, a high-protein diet, and cornstarch at bedtime and upon awakening. At 16 years of age, with advancing liver disease, including ascites, portal hypertension, massive splenomegaly, and bleeding varices, the patient was referred to UCLA for liver transplant evaluation. And at 17 years of age, the patient underwent cadaveric liver transplant at UCLA without complications. Patient is now 30 years old and roughly 13 years post-transplant. The patient's transplant course has been overall uncomplicated. He did get reevaluated for cirrhosis due to thrombocytopenia and splenomegaly, but liver elastography was reassuring, and concern for possible liver rejection was ruled out by liver biopsy. He is maintained on immunosuppressive treatment with stable graft function and liver enzymes. His muscle strength and tone have improved, and seizures are well controlled. He continues with static intellectual disability. He is able to perform most activities of daily living, but he is unable to live independently. Our patient's case history mirrors the findings of Fernandez et al. 2020, with our patient presenting in childhood with hepatomegaly and presenting clinically with intellectual disability, short stature, abnormal liver functions, muscle weakness, and liver biopsy with cirrhosis. PHK enzyme analysis was deficient, and gene sequencing identified 2 mutations in the PHKG2 gene consistent with GSD IX gamma 2. He developed advancing liver disease requiring liver transplant at age 17, and his post-transplant course has been uncomplicated, and his clinical course has been stable. The etiology of the patient's seizures and intellectual disability was initially difficult to understand, and we investigated for other causes, including genetic testing for Fragile X and chromosomal microarray, which were normal. We later attributed his seizures and intellectual disability to possible sequelae from unidentified hypoglycemia in childhood. Interestingly, Fernandez et al. Was able to expand the clinical variability of this disorder to include seizures and intellectual disability in a subset of patients with GSD IX gamma 2. Our patient's post-transplant course was uncomplicated, and further studies are needed to understand if transplant excuse me, could positively impact clinical outcomes with improved myopathy, hypotonia, and intellectual ability noted in our patient. Again, I want to thank the AGSD for the opportunity to speak today and share our case study. I also want to thank the GSD community at large that provides continued inspiration to me professionally as I have the honor and privilege to serve this patient population. Thank you.